approach to gram-positive infections. And as Dr. Chawla sir just mentioned, that they are not all that common in our ICUs as compared to the gram-negatives, but we do see quite a fair share of gram-positive infections. So the objective of today's talk is to basically identify what gram-positive infections we deal with. When do you suspect MRSA and vancomycin-resistant enterococci clinically? What drugs you should choose empirically? How do you achieve source control and de-escalation? And how do you interpret the labs when you actually get a report that says MRSA or VRE on your report? So, before choosing the drug, what would be a practical bedside approach? First, you examine, understand, take the history of the patient and see what you're dealing with. Is it a skin soft tissue infection? Does your patient have pneumonia? Are you dealing with a bloodstream infection, UTI, or for that matter, even infective endocarditis? So, this will all begin with your history and clinical examination. Then you assess the severity. How sick is your patient? Is he in shock? Is he hypoxemic? Are you dealing with a device or a source which is infected? How's your host? Is he an immunosuppressed host? Then, are you dealing with resistant bugs? What is the source of infection? Are you appropriately addressing it? If it needs drainage, have you taken measures to do so? And then deciding on the therapy based on the PK/PD, the toxicity profile, the site of infection, and the MIC targets. So you treat the infection, not just the culture report, and escalate only when severity, risk factors, microbiology, or source control fail to justify. So, like I said, gram-negative infections dominate our ICUs, but there is a burden of gram-positive infections as well. And commonly, we see infections with Staphylococcus aureus and Enterococcus species, and commonly bloodstream and urinary isolates is what we often see. Now, these add to the morbidity because there is prolonged antimicrobial causes. It prolongs your patient's ICU stay, ultimately hospital stay, increase costs. So stewardship is what matters because it would prevent overuse of vancomycin and linezolid like drugs. And cephalosporin also exposes to exposure selects enterococci. So infection prevention and control measures need to be in place to prevent the MRSA and VRE from occurring. The gram-positive organisms that we often see are staph, staphylococci, streptococci, enterococci, and other gram-positive bacilli like Clostridium, Listeria, Corynebacterium. So, what are the resistance mechanisms by which the gram-positive bacteria actually develop resistance? So, for methicillin-resistant Staph aureus, it is the MEC and MEC gene which alter the penicillin binding protein 2A. And what does this do? It makes your usual penicillins, cephalosporins, and carbapenems resistant to that Staph aureus species in your patient. So then your drug of choice becomes vancomycin, linezolid, daptomycin, or ceftaroline, depending upon your syndrome, what site of infection you're dealing with. Then another variety of staph resistance is with the heterogeneous vancomycin intermediate Staph aureus and the glycopeptide intermediate Staph aureus. So this basically the mechanism of resistance is because of the thickened cell wall. So what it does is it traps the glycopeptide. So once your glycopeptide like vancomycin gets trapped in the cell wall, the response to a drug like vancomycin will become poor. So then what do you need to do to treat such resistance? You need to check the source control, consider alternative therapies, and check the MICs as well. Then Enterococcus can have ampicillin resistance because of low affinity for the penicillin binding protein 5. So there is overproduction. So ampicillin may fail in serious disease. Again, then you have to look at the species, the MICs to decide about the treatment for this Enterococcus. Then there is high level aminoglycoside resistance, which occurs because of aminoglycoside modifying enzymes. So drugs like gentamicin and streptomycin, the synergy gets lost. So then in patients with E. faecalis infective endocarditis, you can use ampicillin and ceftriaxone. Then vancomycin resistance enterococcus. This occurs because of the VAN-A, VAN-B resistance, which alters the ALA target. So what happens? Then again, your vancomycin and teicoplanin for this enterococcus becomes ineffective. So your drug of choices become linezolid and high-dose daptomycin, depending upon the site of infection. So to keep these in mind whenever you're dealing with a patient who you started on treatment is not getting better, because there is a possibility of resistance mechanisms as well. Now, where does gram-positive coverage matter? There are patient factors. So a patient who presents with purulent skin soft tissue infections, abscesses, there are lines or devices with prosthesis in situ which seem like the possible cause of infection. A patient who got better after the initial influenza infection and comes back with a cavitating pneumonia. You're growing gram-positive cocci in blood culture. And then, of course, the endocarditis or the embolic phenomena patients. Do not use gram-positive coverage alone for patient who is in septic shock with an unknown source, just because you want to give a broad spectrum coverage, which is very commonly done and a lot in the Indian ICUs. Don't do that. A patient with uh, ventilator-associated pneumonia or intra-abdominal infections where MDR gram negatives are common, and patient with an aspiration pneumonia without MRSA risk, just don't add gram-positive cover. You have a patient who has a positive urine culture with a gram-positive bug, but there is no way possible that the patient has a UTI. Do not treat the patient with just because there's a report that says positive. Rule out colonization. Fever in ICU without clinical localization. It could be a non-infective fever. So you need to know when to actually appropriately add gram-positive cover. So let us look at the drugs that we commonly use and their specific mechanisms and site of action. So we have beta-lactams, that is penicillin, cloaxacillin, cefazolin, ceftriaxone, glycopeptides, vancomycin, teicoplanin, dalbavancin, and oritavancin. Then oxazolin dinones, that is linezolid and tedizolid, lipopeptides, daptomycin, then tetracyclines like doxy and minocycline, and trimethoprim sulfamethoxazole. So, vancomycin. A few aspects of vancomycin that I would like to tell. It is a drug of choice for serious MRSA infection. Given in critically ill patients, you have to reassess the doses and monitor the patient's changing renal function, monitor dosing, and give it a lot of precautions in patients with AKI and CKD if you really have to. Look at the dosing in patients on ECMO, CRRT, obese, burns because of ARC. We've talked about this in the previous session. Then when you're using this with any other concomitant nephrotoxic drugs, because these things you have to keep in mind before you're choosing vancomycin as your drug for MRSA infection. Then in suspected serious MRSA infection, the dose of vancomycin loading is 20 to 25 mg per kg, the actual body weight. Maintenance is at 15 to 20 mg per kg, IV 8 to 12 hourly initially. And then, if it's possible to do therapeutic drug monitoring, or if you can do the AFC guided monitoring, that is preferred if it's available. The target is to keep the AUC 24 over MIC between 400 to 600. You want to avoid toxicity because one, we already know it is a nephrotoxic drug. Give it with precaution with other drugs in combination with drugs like piperacillin, tazobactam, unnecessarily prolonging the duration, review the course, review for how long do you want to give. And if you get culture reports and it shows MSSA, then you switch to cefazolin or cloaxacillin. Do not just continue vancomycin because it works. Then the second drug that we often use is the teicoplanin. The dose of teicoplanin for routine skin and soft tissue is 6 mg per kg BD for 3 doses, and then followed by 6 mg per kg once daily. Loading is the most important aspect of this drug, which I want to emphasize on today, because generally you would see people writing 400 mg IV once daily or 600 mg IV once daily. Don't forget that in severe infections like sepsis or bacteremia, or even deep high inoculum infections or osteomyelitis, the dose is 12 mg per kg BD for 3 doses in severe infections and sepsis pneumonias. And for deep-seated infections, it's up to 5 doses BD, followed by 12 mg per kg once daily. Do not forget to load Teicoplanin. Don't just write OD dose. It is very important because it is actually often the failure of giving loading dose, not the infection that you're treating, which is not getting better. Then Linezolid, which we use as pulmonologists as well, we use it a lot for MRSA pneumonia because it has excellent lung penetration and it is the recommended option for MRSA CAP as well. You have to monitor for toxicity in these patients. So remember that a patient who has been put on linezolid and begins to have thrombocytopenia the very next day, it is not because of linezolid. It takes a little while for the linezolid to actually cause thrombocytopenia, usually about 5 to 7 days minimum, and it can also cause anemia. When given with SSRIs or MAO inhibitors or tramadol, it can cause the serotonin toxicity. Risk: avoid prolonged unmonitored causes because it can lead to optic neuritis, peripheral neuropathy, and even there's a risk of lactic acidosis. And it is a bacteriostatic drug, so you have to consider the severity and the source of infection before actually choosing it as a drug of choice. In high inoculum deep-seated infections, you might consider daptomycin instead of linezolid. And because the oral bioavailability of this drug is efficacious and equally good, you can switch to oral when you're stepping down your patient from IV treatment. The next drug that we're going to look at is daptomycin, which is a great bactericidal drug, but it is site-specific, used in MRSA bacteremia, right-sided endocarditis, catheter-related bloodstream infection, and VRE bacteremia. We have talked enough about this, and I cannot not emphasize again today. It is not a good drug for lung pneumonia because it is inactivated by the pulmonary surfactant. Do not use it in patients with pneumonia. The dose is for MRSA bloodstream infection, 8 to 10 mg. And for VRE ephesium, it requires a higher dose of almost 8 to 12 mg per kg. Then you have to monitor baseline and weekly the CPK values, and also with patients on statin, watch for renal dysfunction, patient developing myalgia, and especially monitor when the patient is on prolonged therapy. Ceftaroline is the beta-lactam, which has activity against MRSA. So it is useful in MRSA, skin soft tissue infections, MRSA CAP. It has been used off-label as a salvage combination for persistent MRSA bacteremia. It has good beta-lactam killing, MRSA penicillin protein binding 2A activity, and a good tissue penetration. It is not a drug for VRE. So don't mix it just because it has activity against MRSA, and in prolonged use, you should monitor for neutropenia. Now you've understood the basic bugs and you've understood the basic drugs that we use for patients with gram-positive infections. If you combine them wrongly, then you will not be able to achieve the desired outcome and your patient will not get better, worsen only. So I just told you daptomycin for pneumonia cannot be given because it's inactivated by the lung surfactant. Vancomycin for MSSA when beta-lactam is possible because it has inferior outcomes. So switch your patient to cefazolin, cloxacillin, nafacillin, or oxacillin, which are the MSSA drugs. Linezolid for simple cystitis, only because your report is showing vancomycin resistant. Don't do that. It could be a colonizer. Check the symptoms, look at the patient syndrome. Is it possible that this patient has a VRE UTI? Only then think of. Otherwise, not linezolid, but think of the drug. Otherwise, it could just be a colonizer. Then cephalosporin alone for enterococcus. It has intrinsic poor activity. So give ampicillin for susceptible, and if it's VRE, then you treat accordingly. If you give rifampicin in uncontrolled bacteremia, it has a risk of developing rapid resistance. So do not institute just because you want to give combination. And it should be used with great caution when you're giving it as a combination in selected patients with prosthetic infection. Then source control. I think we've been talking about this in all the lectures that we've had before, that Just getting your cultures, starting your antibiotics is not enough. You have to drain that abscess, that empyema, treat that septic arthritis, remove that infected central venous catheter, or replace it, debride that necrotizing fasciitis wound. If needed, repeat imaging. If your patient is having persistent fever and you have started on adequate therapy. So, just don't blame the drug. You have to check the source, and unless you achieve source control, you will not get the desired outcome. Now, since I was talking about the bugs, let's look at the bugs a little more in detail, starting with Staphylococcus aureus. So, a Staph aureus infection in blood is not a contaminant unless you have a very strong reason. So never ignore it. It can cause metastatic infection. So you have to be sure when you're treating a blood staph. Source control is mandatory. You have to remove that infected source. Follow-up blood cultures are a part of treatment. They are not optional. Unless you get a negative culture, you must repeat them every 48 to 72 hours. And MSSA must be treated with an anti-staphylococcal beta-lactam whenever possible. So there is an entity called MRSA CAP. What is it? What would you suspect? What would be the clinical triggers? So a patient who comes with a community-acquired pneumonia is very sick, requiring ICU admission, develops shock, comes in has ARDS. A patient who was doing well after his initial influenza infection and now comes with a large consolidation. A patient having necrotizing, cavitating, or infiltrates, or maybe empyema, but it has to be correlated. Neutropenic patients, a patient with erythematous rash or a concomitant skin soft tissue infection, and those who have known MRSA colonization or close contacts with MRSA carriers. Then there are certain environmental clues as well. History of IV drug use, recurrent boils or nasal colonization, recurrent hospitalization. Those who live in close knit contact settings like prisons or army barracks, an immunocompromised host can have any infection. So this can also be a possibility. Then there is skin and soft tissue infection with methicillin-resistant Staph aureus. So practical algorithm to approach it would be that if there is an abscess, you do incision and drainage. If it is mild, add an oral drug. If it's a systemic infection, add MRSA cover. Necrotizing infection, you have to operate the patient. And then once you've achieved adequate control, de-escalate once the patient is showing response and you've got your cultures as well. So for MRSA skin and soft tissue infections, for a simple abscess after the initial incision and drainage, you can give trimethoprim, sulfamethoxazole, doxycycline, and clindamycin if there is a systemic risk. For cellulitis, which is non-purulent, beta-lactam is usually an adequate cover. For purulent cellulitis, trimethoprim, sulfamethoxazole, doxycycline, clinda or IV vancomycin if there's severe infection. Necrotizing infection, you have to operate. Do not delay the debridement and add vancomycin or linezolid plus a broad gram-negative and an anaerobic cover initially. You may de-escalate later, but initially you must cover all. A patient with uh, severe diabetic foot, again MRSA with gram-negative anaerobic cover depending on the severity, but you have to image, you have to debride that diabetic foot and take a vascular opinion early because sometimes these patients require amputation. So I was just talking about the necrotizing soft tissue infection. How would a patient present? There would be pain out of proportion, rapid progression, shock, necrosis, crepitus, commonly caused by group A streptococci, Staph aureus, MRSA, Clostridia, mixed aerobes and anaerobes. And treatment, like I said, you cannot delay surgery. It has to be urgent and broad cover should be given along with toxic suppression. So what do you do in patients when you are dealing with MRSA bacteria in the first 24 hours? You start active IV therapy with vancomycin, if it is possible to do AC guided, that is the best, or daptomycin. If bacteremia or right-sided infective endocarditis phenotype, repeat blood cultures every 24 to 48 hours. If not, then at least 40 to 72 hours, because sometimes there are certain constraints. Remove the infected source, drain all the collections. Echo transthoracic should be done in all patients, and transesophageal when there is higher risk, persistent bacteremia, prosthetic valves, devices in situ, and you don't know the source, and actively search for metastatic foci. So how do you differentiate the Staphylococcus aureus bacteremia? It can be uh, complicated and uncomplicated. So an uncomplicated Staph aureus bacteremia would have negative follow-up cultures at 2 to 4 days. They may have fever, or it might settle very early within 72 hours. They won't have any risk factors of endocarditis, any prosthesis in situ, or any possibility of metastatic infection. A complicated Staph aureus bacteremia would have persistent symptoms, persistence of fever, persistent positive cultures, confirmed or possible infective endocarditis. There is going to be a valve, device, or joint in situ which needs review, could be the source. And then, of course, metastatic infection. So you have to have bone joint evaluation, epidural abscess, or emboli. So this is the basic difference between the Staphylococcus aureus bacteremia, uncomplicated and complicated. Now, the duration of treatment. So, just told you about the MRSA bacteremia. So, for an uncomplicated staph bacteremia, 14 days from the first negative culture. For complicated, 4 to 6 weeks. Right-sided infective endocarditis, 4 to 6 weeks. Left-sided infective endocarditis or prosthetic valve, usually more than 6 weeks. Osteomyelitis or epidural abscess, at least minimum 6 or more weeks. And of course, for these uh, collections and abscesses, you need to have drainage and decompression. It has to be done simultaneously. You have to stabilize your patient and do it. What could be the reason if your patient still continues to have persistent MRSA bacteremia? It can be because of an undrained abscess, infected thrombus, there's a retained line or device. So, unless you actively rule out the sources and achieve adequate control, you will not get the desired outcome. Your patient will be persistently symptomatic. You repeat cultures, look at the MIC confirmation, do therapeutic drug monitoring, check for toxicity if needed, and salvage options if, in spite of achieving everything and doing a good source control, you can consider a high dose daptomycin if there is no pneumonia source, and ceftaroline based combinations in selected persistent MRSA bloodstream infection patients. The second bug that we see is the Enterococcus and VRE. So we know it is a facultative anaerobe, and it is a commensal in GIT. It survives on surfaces, bed rails, doorknobs, and we see clinical syndromes. We see UTI, bloodstream infection, infective endocarditis, abdominal infection, CNS, skin, and soft tissue. E. faecalis and E. faecium cause most of the diseases. For faecalis, ampicillin is often susceptible, and for E. faecium, it's mostly resistant. It's a VRE, and you have to accordingly decide for therapy. So the basic difference between the common enterococcus, that is faecalis and faecium. Faecalis you would see commonly in patients with UTI, infective endocarditis, intra-abdominal infection. Faecium is often healthcare associated bloodstream infection, and there is vancomycin resistance. Ampicillin is susceptible, and therapy is always ampicillin based. And if there is E. faecalis and endocarditis, ampicillin plus ceftriaxone become your drug of choice. For E. faecium, it is often resistant to ampicillin, as well as vancomycin is even more common. So therapy is with linezolid and daptomycin if you're dealing with VRE. And for endocarditis, it has to actually, you have to take your ID specialist, you have to discuss with the microbiologist and decide about the line of management. So VRE epidemiology and impact in India. It has been seen that the prevalence is low, but it has risen from 4.8 in the 2000s In 2020, it had almost become 14.1%. So, what are the mechanisms by which Enterococcus develops this vancomycin resistance? So, there's VAN-A resistance, which is high level of vancomycin resistance, and in VAN-A, it is often even resistant to teicoplanin. So, you use linezolid or daptomycin if you're actually dealing with true infection. And in VAN-B, it is vancomycin resistance, uh, but it may be sensitive to teicoplanin. But do not rely on glycopeptide without an expert input. You just cannot start giving teicoplanin. This has to be correlated even clinically. Now, in cases of VRE, whether you're dealing with a colonizer or a true infection, how would you differentiate? What would you actually look at? So, a colonization could be a patient with a rectal screen positive, no clinical syndrome, a urine VRE with no urinary symptoms. A patient has not ever undergone any urological procedure, and suddenly you've got a VRE on his urine sample in the culture. A drain or respiratory culture, and there is no presence of any obvious respiratory symptoms or any um, consolidation or any positive findings on your radiology. Then mixed intra-abdominal culture after source control and clinical improvement. It's usually, colonizers that you're dealing with. So, and when is it actually a true infection? When there is bacteremia, when there is an endocarditis or an infective device, symptomatic UTI, pyelonephritis with VRE, intra-abdominal sepsis with higher risk of VRE, and persistent fever or sepsis, and you're, actually getting VRE from sterile sites. So this is where, you have to treat the VRE infection seriously. So just to summarize, how would you approach a patient with VRE bacteremia? First, understand what you're dealing with, Ephesium faecalis, which would come on your cultures. Check the MIC, check what drug, whether you can give AMPI, Vancol, Linezolid, or Daptomycin. Where is the source? Is it your line? Is it abdomen? Is it urine? Is there any persistent bacteremia? If yes, you need to repeat blood cultures until clearance. Can you remove that line? Have you removed that line? Have you drained the source? And look at your host. Are you dealing with a neutropenic or a transplant patient or a patient who's critically ill and septic shock? Then, your threshold has to be even more aggressive in such patients. A word about VRE bacteremia and linezolid and daptomycin. So we all know that linezolid is a bacteriostatic drug. Dose is 600 twice daily. It is a best drug for pneumonias and great for step down. We just told you about the toxicity profile, so you need to monitor accordingly. Daptomycin is a bactericidal, high dose of 10 to 12 mg per kg for VRE and ephesium bloodstream infection. You need to monitor the CPK levels, look for myopathy, and monitor these patients, especially if you're giving them prolonged course. It's not a drug for pneumonia, so do not use it as a drug in patients with pneumonia. Then patients with VRE UTI. So if the patient has asymptomatic bacteria, please don't treat. Don't just treat cultures, which is the habit. You saw the report and you start adding gram-positive cover. Don't do that. For lower cystitis, nitrofurantoin or phosphomycin, if your bug is susceptible and renal function allows. For pyelonephritis or urosepsis, linezolid or daptomycin. If susceptible, catheter associated, replace that catheter first. Sometimes source control is enough. You don't always need to add antibiotic cover. And if you're growing mixed flora in the urine, then send repeat sample. If it is a long-standing catheter, remove the sample. Sometimes achieving source control is, usually enough. You don't need to add antibiotics. Then for streptococci, there are certain common syndromes and drugs like group A streptococci can cause cellulitis, necrotizing fasciitis, toxic shock. So drug of choice is penicillin, ceftriaxone, and you add clindamycin for toxin disease. Group B, strep, bacteremia, diabetic foot, peripartum disease. Again, penicillin, ceftriaxone, vancomycin only if the patient is allergic to penicillin. Strep viridans, endocarditis, so penicillin, ceftriaxone, depending upon the MIC. For streptococcus pneumoniae, Pneumonia, it can cause meningitis, bacteremia, pneumonia. So it would depend upon the site of infection, and accordingly you choose between ceftriaxone and penicillin, and of course based on the susceptibility. Then what are the common mistakes you should avoid? You can't keep continuing vancomycin. I just told you, switch to MSSA cover once you know that it is MSSA and you're not dealing with MRSA. Treating a VRE colonizer. You need to be able to differentiate between colonization and true infection. Using daptomycin for pneumonia. No repeat cultures in, not sending repeat cultures in Staph aureus Bacteremia. You need to repeat until clear. And if you are not getting a clearing of your cultures, then you need to actively start searching for metastatic foci and escalating without source control. You have to drain, you have to remove that line, you have to drain the abscess and do imaging, repeat imaging if needed. So treat the infection, not the culture report. You have to correlate your bug drug and site, which is the simplest way to approach any infection. MRSA coverage should be selective, not reflexive. Staph aureus bacteremia always needs repeat cultures, echoes, and metastatic search. Do not dismiss it. MSSA needs beta-lactam therapy. Daptomycin is not for pneumonia. Linezolid is useful for MRSA pneumonia and VRE, but it has to be monitored for its toxicity. VRE colonization needs infection prevention and control practices and not antibiotics alone. It's majorly the infection prevention and control practices. E. faecalis and faecium are different clinical problems. You need to be able to differentiate, understand the Enterococcus you're dealing with, and accordingly choose your antibiotics. Persistent infection means searching the source before just blaming the antibiotic not working or changing your antibiotics quickly just because your patient is not getting better. Thank you.